Good morning. Thanks for joining us. Welcome to the sixth and final session of our Opioid Prescribing Overdose Prevention Learning Collaborative. I'm John Glover, a Quality Improvement Advisor for Superior Health Quality Alliance, or Superior Health. Superior Health provides support for healthcare organizations in Minnesota, Wisconsin, and Michigan under a federal grant from the Centers for Medicare and Medicaid Services, or CMS. Today's session will focus on recommendation number 12 from the CDC's updated 2022 Clinical Practice Guideline for Prescribing Opioids for Pain. It addresses providing treatment for opioid use disorder, and we will also have a case study to illustrate recommended prescribing practices. This will be our final session of this Learning Collaborative series. Superior Health has also developed an opioid prescribing and overdose prevention toolkit to complement these sessions, and we'll be putting a link to that in the chat following this session. During the session, Yvonne Burston, who's also a Quality Improvement Advisor at Superior Health, will be helping us with questions and comments in our chat, as well as providing links to various materials throughout the session. Before we get started, please add your name, organization, and your role into the chat. And if you have others with you, please include their names as well. A few housekeeping items. We will have one polling question at the beginning of today's session and one at the end of the session. We will also be putting a link to a brief survey for the session in the chat, and we'll give you a few minutes to fill this out. During the session, if you have a question you would like to ask verbally instead of in the chat, please raise your hand and we'll be happy to take you off mute. Dr. Dibble is our speaker today. So Dr. Dibble, take it away.
Thank you so much, John. My name is Rachel Dibble, and I am also a Quality Improvement Advisor with Superior Health. And today we will have our final Opioid Prescribing Collaborative, session 6, and we will go through the recommendation of number 12 and a case study. I don't know if you all were able to attend the other 5 sessions, but in that we're going to put them all together and hopefully it'll highlight 1 through 12 as well for the case study. Next slide, please. So we'll begin today with a polling question. And the question is, when a patient is requesting more pain medication for acute pain related to a hairline fracture of the tibia, the healthcare provider should consider the possibility of drug seeking, tolerance to opioid regimen, pain relief seeking behavior, underlying disease process, or all the above. The learning objectives today will be: participants will be able to understand the CDC opioid prescribing recommendation number 12 and implementation strategies, identify aberrant medication taking behaviors with opioid differential diagnoses, improve knowledge, understanding risk and benefits of opioids, ability to manage patient expectations with opioid treatments. Next slide, please. So CDC's 12th recommendation, they are grouped into 4 categories. So determining whether to initiate opioids for pain, recommendations 1 and 2, selecting opioids and determining opioid dosages to refer back to recommendations 2, 3, 4, and deciding duration of initial opioid prescription and conducting follow-up, and that is recommendations 6 and 7. Assessing risk and addressing potential harms of opioid use, recommendations 8, 9, 10, 11, and finally 12, which we'll come to. Next slide. So opioid crisis in numbers, we're all very aware. It's in the news all the time. CDC obviously has significant data related to overdose, and that is prescription. So let's think about that. Let's take out, obviously we hear people buying drugs and kids dying of fentanyl, et cetera, off the street or wherever they're getting it, out of the garbage, family, et cetera. But these are prescription opioid overdose is totaling nearly 17,000 deaths, and 45 people die each day for prescription opioids. Prescription opioids were involved in 21% of all opioid deaths in 2021. So, it has actually gone up, but the data released is 2 years behind. So we have escalated. Next slide, please. So CDC recommendation number 12, I'm going to read this from the slide. This is actually the recommendation. Clinicians should offer a range of treatment with evidence-based medications to treat patients with opioid use disorder. So that is a disorder. That brings in another topic of stigma. So when we see this, we can't fall in the bucket of stigma, judging someone because they have an opioid use disorder, because we know prescribing opioids, particularly for chronic pain, they will become addicted. We know that. So it is our responsibility to identify opioid use disorder, embrace those patients, get them help, and get them the appropriate treatment. So detoxification on its own without medications for opioid use disorder, it is not recommended for opioid use disorder because of the increased risks for resuming drug use, overdose, and overdose death. So what that means is you got to taper those patients off, because if you stop it, they could go withdraw, and it could potentially cause them to die related to DTs, etc. Withdrawal. Next slide, please. So implementation considerations, you all will have access to this, but I'm going to highlight a couple of these implementations. So patients meeting criteria for opioid use disorder. Evidence-based practice is really important here with medications. We want to also absolutely not dismiss patients. Those patients are our patients. So if they're having issues and they're high risk with their opioid usage, we have to give them transition of care. We have to help them, opposed to this is too much risk as a prescriber and I'm going to let you go. So that is the point of dismissing patients. So we're also looking with OUD, opioid use disorder. These patients typically become tolerant to their dosages. So they are particularly at high risk for overdose because they may continue to take medications not on the regimen, meaning Q4, they may take it Q1 because they're in pain. So that is potential for overdose. We got to look at that. Also referring to a specialist. I've had many patients where I'm like, my MMEs are off the charts with you. I am not helping you with pain anymore. You need methadone, bupropion, you need to go to a specialist. So that referral is very much appropriate. Again, bupropion and methadone, those are the folks that are getting the tolerance. We have to transition them. Look at our community resources. Identify, that's the key. Identify OUD and the effects and benefits of opioid pain. Because if they're tolerant, they're not getting the benefit. Next slide, please. So stigma. This is the highlight of this slide. Stigma can reduce willingness of persons with opioid use disorder to seek treatment because of the stigma. So we have to get out of that culture, because as prescribers, we know the risks of these drugs. So we have to just get stigma out of our thinking. Next slide, please. So here's the case study, and I want you to think about the case study throughout the rest of the talk. So here we are with the 42-year-old woman. She has type 2 diabetes. She has painful diabetic neuropathy and back pain. She presents to the ER or the ED. Patient is currently on extended release or long-acting. So long-acting medication. Oxycodone 20 milligrams and gabapentin for the previous 11 months. So she's been on the oxy for 20 milligrams 2 times a day, gabapentin. So we know she has some chronic pain just from looking at her history. So she's been doing this for 11 months. She's reported that her pain has increased from baseline. So maybe she was at a 3 with this regimen. It worked. And now she's at a 6. So level of 3 to 10 within the last month. So she's escalated. So the question is why, right? So patient, she started taking an extra ER extended release oxycodone in the afternoon, and she ran out early. So that's why she's asking for some more pain meds. We went to the ED a week ago to obtain an early extended release oxycodone refill. The concern is my body has become used to current dose and it just doesn't seem to work anymore. Husband says she has become addicted. States it is difficult to go to work, the patient does, due to severe pain. So we're looking at some economic issues here. She is having trouble sleeping as the sheets touching her feet now cause pain. And she is requesting an increase in her dose. Next slide, please. So when someone is asking for pain medication or we prescribe, our head has to go specifically to these differential diagnoses. So what we look at is pain relief seeking. So disease progression. So that a patient, particularly this case study, is she just looking to relieve some pain? So we need to really study, is this a disease progression potentially of something else? Or is her neuropathy getting worse? Increased activity, poorly opioid response to pain. Case study. That's what she's looking for. Withdrawal from mediated pain, opioid analgesic tolerance. Maybe that's our patient. Opioid induced hyperalgesia. Big takeaway with this pain relief seeking. The next category is pain relief and drug seeking. So this is likely a most common scenario. So we know we've prescribed this person medication, opioids. So they could be addicted. Most probably they are. We have to keep that in mind. So that's that pain relief and drug seeking. This is not a punitive thing. This is not a judgmental or stigma thing. This patient is in pain and potentially addicted or dependent on opioids. So pain without comorbid addiction, patient taking some for pain, diverting some for income. That's how we get it on the streets. This is an economic problem because sometimes these people can't work because of pain. Then we have the person who is just drug seeking. They are addicted. And here we are with other psychiatric diagnoses issues, which is why we cannot judge or have stigma around these people. We know that people with mental health disorders typically potentially go to drugs, alcohol, smoking, and that's part of their mental health issues. It is our responsibility to identify these things, refer on if we can't handle it ourselves. It is important to put our arms around these patients. Drug seeking also, criminal intent, diversion, maybe money, maybe who knows what this could be, but this is your absolute drug seeker. What they look like when they come in, potentially, I'll give a quick example of when I used to work with cancer patients and cancer was cleared. They were still coming in for their Dilaudid and Oxy. I go to the database, I look at the prescriptions, I look at my MMEs. Then I say, hey, your cancer is gone. Okay, do you have neuropathy or maybe some other pain hanging around? These are things we have to investigate before we just write a script. I could not see in that case why we needed a script. I could see some Cymbalta to help with pain. I could see an increase in gabapentin, increase in other non-opioids, non-pharm. This patient potentially was drug seeking. And when I looked in the database, I saw 3 other states. This man had been doctor hopping. If I had prescribed, I was facilitating the addiction. Drug seeking. I was not helping this patient. Next slide, please. Differential diagnoses, again, for pain relief seeking. What we have to look at here is opioid tolerance. And what that is called is a right shift of the dose response. And all we're looking at here is in your head, these are what you think about with your differentials. Dose efficiency curve is that dotted line. That's when it's working. Then we have our toxicity. We're looking at overdose. We're looking at death and morbidity and mortality. And what we want to do is get in between these two lines. And if we start getting to the right shift, we need to stop and think and look at the regimen, see if it's effective, look at the risks. Next slide, please. Differential diagnosis, pain seeking again. This is one of them. And the explanation is opioid-induced hyperalgesia, poorly understood paradoxical effect. We know that by the literature. My son gets Benadryl, he's wired. My other son gets Benadryl, he's asleep. Same concept. Central and peripheral sensitization of anti-analgesic or hyperalgesia process, pain sensitivity increased related to the same opioid dose. So this is the paradoxical effect, right? Increased opioid dose may improve analgesia temporarily with subsequent worsening. We can make pain worse by our regimen of pain. Symptoms improve with decrease of discontinuation or taper of opioids. Discontinuation could potentially be used with your short-acting. If that patient has been on it for 3 days or less, you will not see the withdrawal. Okay. Next slide, please. Differential diagnosis, this is your drug seeker. These are the things you need to look for. Clinical signs and symptoms of addiction, not dependence, addiction. Totally different idea. The 4 C's, loss of control, compulsive use, continued use despite harm, meaning I have no pain anymore, that person is addicted, continues to take them. Craving, I gotta have it. Healthcare providers should be aware, and it's the pattern and severity. Addiction is not the same as physical dependence. Addiction is more of the mental concept, potentially mental health issues, opposed to the physical dependence. Next slide, please. Differential diagnosis, drug seeking continued. Again, psychiatric diagnosis. That is the highlight of your drug seekers. Patient knowingly or unknowingly, that happens all the time. They unknowingly use opioids inappropriately to treat symptoms of mental health disorders and situational stressors. So if they've got some oxy sitting there, they're stressed out, potentially, hearing voices or depressed, you pop an oxy, you're going to feel better. It's normal thinking, but it's huge risk. Fear and anxiety about worsening pain. That is a cycle for your patients. And that's something we have to address. Next slide, please. So your differential diagnoses again with your drug seeker. So visit by an individual. This is what it looks like with or without legitimate medical need. Go back to my cancer patient. I embraced him. I helped him, but I also was aware of the drug seeking. To several doctors, doctor hopping with whom writes prescriptions. You can find that out through your databases. They go to multiple pharmacies and they pay with cash. I have often been called by pharmacists. Why are you prescribing this all the time? They pay with cash. What's going on? They don't want to claim it on medical. These things make my antennas go up. Next slide, please. Managing expectations with your patient. Very big topic. This is a collaborative IDT, patient-centered exercise for managing expectations with your patient. Next slide, please. So lack or loss of benefit. Again, go back to that graph, that tolerance, that right shift. That's what we're talking about. So reassess factors affecting the pain. This is a conversation, and it's a long conversation. I understand the time constraints with the provider. But opioids is when you just stop. You just have to stop and really be mindful about this. Treat underlying disease and comorbidities. I've seen that 100 times, particularly with back pain. I refer them to PT. PT calls me, hey, there's a bigger problem here. Oh my goodness, I need a CT. And then potentially I can think of a patient, I had cancer. That's why they had more pain. If a dose is escalated, consider performing a test. That means Not punitive, not judgmental. I need to see what's in your system to make sure that I am not giving you something else that could potentially give you harm. If a dose is escalated, again, consider performing a test. Consider adding or increasing adjunct medications. I love the Cymbaltas. I love particularly gabapentin. That's me as a prescriber. Do not get into the opioid world. Sometimes tramadol will work. Anyway, consider adding breakthrough pain medications, particularly with your long actings. They're going to have breakthrough. You may want to start them on Tylenol before you give them a hydrocodone for breakthrough. And then opioid rotation consideration. That's when your tolerance is there. You may want to try something else, adjust the dose, even lower the dose because of the paradoxical effect. Next slide, please. Managing patient expectations regarding lack of continued benefit. Big key. Not all pain is opioid responsive. It's like any other drug. You might get a response, I might not. So we have to be mindful. More opioid is not always better, right? Shift, toxicity. We got to be mindful. More opioid may increase risk of adverse effect. Again, we may be causing them more pain. Remember, patient may have developed opioid-induced hyperalgesia and will improve with the tapering off of opioids. So we're causing more pain. Things to be mindful of. Next slide. Managing patient expectations, again, opioid-related adverse effects, toxicity, induced more pain, and then addiction. Psychosocial, we got to look at those psychiatric conditions. Again, storage of opioids, unsafe housing, really important. Noncompliance with monitoring, use of illicit drugs. Sometimes that's your mental health patients in conjunction with opioids, diversion or criminal behavior. Next slide, please. Clinical tips for interviewing your patient. Compassionate, empathetic. Express understanding of your patient's frustrations. They're frustrated. I'm in pain. Help me. Focus on patient's strengths. Maybe they keep logs. So continue to keep that log and bring it in. Encourage and discuss therapies for coping with pain. That can be your depression. Pain usually equals depression. You're in pain. Show commitment to the patient for their pain concerns. Again, don't dismiss them. Don't judge them. Schedule close follow-up for visits and during and after tapering patient. Make sure they're okay. Next slide, please. And then unrealistic expectations. Sometimes patient has unrealistic expectations. So opioids always equal chronic pain relief. More opioids equal more pain relief sometimes, which often results in unsanctioned dose escalation, again, causing more pain. So the health provider needs to reset with realistic goals, potential severe risks and harms with opioids. Next slide, please. Referral. So understand what services the pain specialists offer. So they help you with the pain. They give other treatment options. They collaborate with colleagues, multiple patient prescription narcotics, opioids, abuses of addiction to alcohol. All those things need to go to a different specialist. Next slide, please. Misunderstandings. Often family members and patients often misunderstand what physical dependence and tolerance versus addiction means. So again, we need to re-educate the dependence, tolerance, and physiologic adaptations to chronic opioid therapy. Addiction is a maladaptive behavior associated with opioid misuse. Next slide, please. We got to monitor. Do a pill count, urine screening, prescription drug monitoring program data. That's your database. And history from a reliable family member. Be aware of family members with potential gain for giving inaccurate information. That's your diversion. Next slide, please. When to discontinue. Diversion, addiction, unable to take opioids safely, determine how urgent the discontinuation is, Document rationale for discontinuing. Protect yourself. Determine if the opioid needs to be tapered. Determine degree of physical dependence. Higher intensity from withdrawal. Higher steady state levels, longer term exposure, and faster rate of medication clearance. That's your half-life. Next slide, please. Decide if you need to taper the medication. Look at your physical dependence, look at the quantity, and build up alternative treatment plan as well. Next slide, please. Decrease by 10-20%. Look at your breakthrough pain and your withdrawal symptoms. Also, alternate pain treatment strategies. Next slide, please. Reassess patient to continue or discontinue. So here are your benefits, your risks, your harms. We've gone over that. Avoid these pitfalls. This is what your patient's going to say. I really, really need it. Do you trust me? I thought you cared about me, etc. So those are the times where the provider needs to explain, I don't want to harm you. I'm looking at this and there's potential. Next slide, please. So here's our case study. So over the next 12 months, medications, they were adjusted. That's what she needed. They titrated the methadone. She needed methadone. She clearly had an addiction, and her pain was not being helped. So 10 milligrams 3 times a day, gabapentin, they maxed out her dose, 600, which is 1,800 a day. Amitriptyline, that's antidepressant as well. Acetaminophen, great breakthrough pain to start with. Monthly chronic pain support groups, that's the community part. And she was adherent to all of this. And she had no aberrant medication taking. So she falls in the bucket of she was just in pain and needed help. Next slide, please. So here's your last polling question. Same question. When a patient is requesting more pain medication for acute pain related to her hairline fracture of the tibia, where does she fall? Which one does she fall in? Okay, I'm going to just go move on. We're a little bit tight on time. Okay, next slide, please. Here are your takeaways, 1 through 12. Assess, reassess. Prescribe naloxone. Please, please, please. Check your database. Look for respiratory depression with opioids. Tox screening, shift to the right. Assess for history of overdose, taper medications, bowel regimen. We don't want perforated bowels. It happens all the time with opioids related to constipation. Know when to refer. That's big right here. Okay. Next slide, please. Any questions, please put in the chat. We're here. Also, a lot of these are 1 through 5, 1 through 4. You can look at YouTube with all the recommendations. Any questions? John, I'm going to hand it over to you. And I thank you so much. And if you would please fill out the survey so we know what you enjoyed and things we could do better. And I appreciate you taking 30 minutes out of your day. Yvonne has put in the link as well.
Yeah, thanks so much, Rachel. Yvonne's going to put a link to our toolkit in the chat for you if you don't have that yet, so you can use that as sort of a quick reference. Also, on this slide, you'll see that we have Superior Health's Connect link. If you haven't joined us already there, please do. Connect is used as a platform to share information and continue these conversations, as well as conversations about a variety of healthcare topics. So this concludes our presentation today. You'll see a link to today's slides in the chat. We wish you all a good day, and thank you so much for joining us. Remember to join us at Superior Health Connect to continue this conversation.
Thank you so much.